Hi, everybody. Today we're going to be talking about Chapter 7, and that's talking about the patient with cancer. So if you would go ahead and turn with me to page 102 in your books. I'll go ahead and share my screen. Started. There we go. All right. So again, talking about the patient with cancer. As always, our chapter begins with your objectives, so make sure and read through those. Make sure you're understanding each one of those objectives for your chapter. Okay? All right, so let's start out talking about some of the statistics of cancer. Cancer is the second most common cause of death in the United States. As many of you, I'm sure, have experienced. Most of us know either it's ourselves, a family member, a close friend, a coworker, friend of a friend who has dealt with cancer. And most of us know quite a few people who have. Even working in the healthcare setting, the patients that we work with. And so your book talks about all of these different types of cancer. And on page 103, there is a chart that talks about the leading sites of new cancer cases and deaths in the United States. And this is giving you estimates from 2017. It's kind of funny, isn't it, from a new book, but it's been out for a little while now. And so, of course, those update every year. But it's really fascinating to see, the statistics there. Again, estimated that 1 in 3 Americans will develop cancer sometime during their lifetime. Isn't that crazy to think about? Look at the person to your left and to your right if you were sitting in a normal class setting, and think about that 1 in 3 will be diagnosed at some time during their lifetime. There are different types or sites of cancer for both men and women that are more prominent. For example, page 103, if you would turn there, let's see, it talks about the very top one, talks about the estimated new cases. Look at the male and female. What's the top one on the chart? Well, for females, 30 to 31%. Highest cancer for women is what? Breast cancer. Okay, and for men, prostate cancer. We'll talk about those a little bit more when we get to the end of MedSearch 2. And we'll get into talking about some of the statistics that include those. Okay. Now, when we're talking about cancer, you have benign, which means non-cancerous, okay, or malignant. Malignant means cancerous tumors. So you've got benign versus malignant tumors. You've got normal body cells, which are the cells that are in our body every day. And you have benign tumors, tumors that have developed, overgrowth of tissue and so on, but there's no cancer in those cells. And then you have your malignant tumors where they actually have cancer, okay? So there's different characteristics of each type of these between normal cells and between malignant cells. So if you look at page 102, 103, right there at the beginning, it begins to differentiate between those two types of cells. Tells you what the characteristics are of the normal cells, and then it goes into talking about, benign tumors, again, where you have they're basically harmless tumors. Something to remember, and is key, is that between benign and malignant tumors, they can have some things in common too. And that's that they can grow to the point that they begin to put pressure on nerves, they put pressure on adjacent tissue, organs, and so on. And so they can cause pain. They can disrupt the flow of blood, all kinds of things. So just because they're not cancerous doesn't mean that they don't cause problems, okay? For example, take somebody who has a benign brain tumor. Well, what surrounds our brain? Our skull, right? So if something grows and puts pressure on that skull on the inside, if it hits that final amount of pressure where it can't go any further, what begins to happen? Then it begins to push inward, right? That causes pain. It's going to cause disruption because it's going to put pressure on areas where pressure shouldn't be, right? So all kinds of issues can develop, okay? There's a term that's called neoplasm that your book talks about. That's on page 103 as well. Cells can reproduce abnormally in an uncontrolled manner and form what's called neoplasms or tumors, okay? And such cells, again, can be either benign or malignant, okay? Again, benign tumors can become problematic, especially in areas where space is limited and confined, like I said, within the skull. Okay, so that's another thing to remember. Okay, um, there's another term on page 104 that's used, and it asks you what are tumors that are found away from the original site of malignant cells called? Well, they're called metastases. That means cells that travel from where they originally started and go somewhere else. They have metastasized and they become metastases, cells that have moved elsewhere from where they originated. Okay? The next term we want to talk about is called malignant transformation. This starts on page 104. Okay? Factors that promote the transformation of normal cells into malignant cells are things like increasing age, diet, hormones, and chronic irritation. We have substances called carcinogens. These are substances that actually damage our DNA, okay, that causes normal cells to then become malignant cells. Okay, for example, somebody who smokes and they are exposed to what? What's in cigarettes? Nicotine, right? And that's a carcinogen, which means it's a cancer-causing substance. So the more that somebody is exposed to those, it begins to damage the cell's DNA, like in the lungs, which causes those normal cells to then become cancerous. Okay, perfect picture of that. Okay, a person's general emotional and physical health also may be factors in promoting or slowing the growth of cancer cells. Let me give you one example of that. Let's say you have somebody who's just really positive, upbeat, they tackle life as it goes, and they happen to get diagnosed with stage 4 cancer, but they go way beyond when the doctors think that they should have survived. And some of the theories are things like they are constantly staying positive, so their body's producing all those happy hormones that help to flood your system with all the things that it needs that are good. Also helps to, for example, let's say they keep exercising and doing things, they're constantly burning off adrenaline and any negative things, and they eat really healthy, so maybe their body's, able to fight off the disease better because their nutrition level's high, just all kinds of things like that, can play into the role of how somebody's body fights off cancer. Now, sadly, there are other times when you look at somebody and say, wow, they're the healthiest person I know, and they died of cancer. Those are just crazy. We can't explain them, right? That would give us a cure for cancer, wouldn't it, if we could explain those things? Okay? There are also 4 steps to malignant transformation. It's the process from when, again, a cell is normal and progresses into becoming malignant, even into the worst stages. Okay, so those 4 steps of malignant transformation are on page 105 in table 7.2. Study that table really well. You're going to want to do that. Okay, the 4 steps are initiation, promotion, progression, and metastasis. Okay, so when you look through that section on your book, you'll see how it's got the step, then the process, and then the effects on the cells and tissues. Make sure you study each one well and look at how they progress. I don't want to confuse you. The 3rd step is progression because, again, it progresses, but think about it. Initiation. This is where the DNA is first exposed to a carcinogen, okay? And then irreversible changes occur. So then what are the effects on those cells and tissue? Well, the cells appear somewhat abnormal, and they probably continue to function normally at this stage because this is right when it starts, okay? Then we have the promotion stage, which comes next. This is where sufficient exposure to an agent or a promoter is to encourage or enhance cell growth. So what happens here? This is the latent period. Latent's another word for kind of sleeping, taking it easy, going dormant, okay? This is the latent period before increasing growth forms tumors. This is where we would call the early detection stage. So this is the stage, the promotion stage is right before it begins to take off, which is the progression stage, okay? Where you see accelerated growth, enhanced invasiveness, meaning it's invading the tissue that's around it and even going more. Altered appearance and biochemical activity begins to occur. And then what happens? You have tumor develop, and on goes the process. I won't finish reading that one. And then you go to metastasis. This is where the tumor develops internal blood vessels. It produces enzymes that dissolve substances that typically would hold normal cells together. What happens if you dissolve those walls? It begins to spread, right? And then what happens? Transformed cells relocate by direct extension, invasion, and establishment of remote sites, right? It metastasizes. Metastatic cells that develop now in different areas where they didn't start. Okay, so really study through that table. That's an important one for you, okay? Then you have the classification of tumors. You have the anatomic site. That means where is it? Where did it start? Okay. And then the staging system for cancer. You're going to want to study the staging system well. Because if you are presented with a patient and you're given each one of these letters with numbers, you should be able to figure out where they're at in the process. For example, this is a picture that I pulled up, but your book has the chart directly in there. Use the chart in your book. It's on page 106, top of the page, table 7.5. Okay, and it talks about this again. So it starts with the first stage. I'm going to use the chart in your book. Okay, so primary tumor. T stands for tumor. Okay, T0, no sign of the tumor after treatment. Okay, TIS, malignancy in the epithelial tissue, but not in the basement membrane. T1, minimal size and extension. T3, progressively increasing in size and extension. And T4, large size and extension. Okay? Now, regional lymph nodes. Is it in any of the lymph nodes? So N0 means it's not found in any of the regional lymph nodes. None of them are involved. N1, minimal regional lymph node involvement. N2, increased involvement in the regional lymph nodes, so around the region. Okay, and then there's N3. This is extensive involvement of the regional lymph nodes. Okay, and then M. This is where we talk about metastasis. Okay, M0 means there's no distant metastasis. M1 means there is distant metastasis present. Okay, so learn what each one of them means and how each one of them progresses to go higher and higher. Of course, meaning it's spreading more and more and more. Okay, so for example, if I have a T1, N0, M0, that's going to be way low, right? As opposed to somebody who has a T4, N3, M1, they're probably going to be in pretty rough shape. Follow me? Because the tumor size is large, all of these lymph nodes are involved, and it's metastasized elsewhere, right? So we're way down the stage on progression. Okay, so know how to use that TNM system, and be able to figure that out. Okay, another term that's used on page 104 is differentiation. When we talk about cancer cells, differentiation refers to how cells are different from their parent cells or the tissue of origin. So maybe you have a cancer cell that started in the breast, but then it moves elsewhere and it becomes a differentiated cell. Okay, we still know where it came from, but it has differentiated from where it came from the origin. Okay, when it's difficult to recognize the original type of tissue from which tumor cells came, they are described as poorly differentiated cells. So let's say somebody has colon cancer, okay, and then it metastasizes to the liver. Okay, well, let's say that by the time they find it, it's quite extensive in the liver, and those cells have morphed to become crazy, and they've infiltrated the areas of the liver. And then when they go to look at those under the microscope, they're very undifferentiated. Like they're trying to figure out, did it come from, maybe it's a female patient. Did it come from the colon or did it come from the breast? We can't quite tell. You know what I mean? I'm just giving you a random abstract. figure, but just to understand they're hard to tell where they came from. That would be poorly differentiated. Now, when cells are well differentiated, that means it's very easy to recognize the tissue of origin, where they came from. Okay, staging is done at the time of diagnosis and again at intervals during and after treatment. So when the person gets diagnosed, they will stage, where the cancer's at, and then they will monitor the progression. And if they're going to treatment to see how successful it is, okay? So it helps us to plan treatments and to predict long-term survival, okay? So again, table 7.2 on page 105, I'm sorry, 106, I wrote it wrong in my notes. The different steps that you want to go through. Oh, actually, I am telling you right, I just wrote down the number. Hang on one second. Right here. Yes, I'm sorry, table 7.2, page 105. That was correct. Okay. Again, follow each one of those steps in the transformation of normal cells to malignant cells. Initiation, then promotion, then progression, and then metastasis. Okay. So make sure you understand those, right? Okay, the next thing we want to talk about are risk factors. And I'm sure you hear it all the time because we've become so much better at educating people on the risk factors for cancer. So you've got genetic and environmental factors. Changes in genetic information of a normal cell can cause alterations that lead to malignancies. Okay, you've got carcinogens, drugs, familial cancers, and hereditary cancers. Okay, so as we talk about these, a single specific cause of cancer has not been identified. We hope so someday to have that. They're getting closer, I think, but we don't have a single specific cause as of yet. Other factors, again, that are thought to be associated with cancer development are things like increasing age. The older we get, it's kind of like the longer we've been around, the higher the chances that we're going to get something, right? Heredity, does it run in your family? Have we seen a lot of different, let's say, do we have multiple family members who have breast cancer or multiple family members who have prostate cancer and so on, okay? As well as hormones play a big role as well. Now, another term that you may hear about is called genetic counseling. Now, genetic counseling is for people who have family histories of familial or hereditary cancers. So genetic counseling can be it can direct the person to the appropriate screening to get done and the lifestyle changes they may want to make to serve as a basis for making decisions about even reproductive options. Okay, so let's say, for example, let's say you have a family, and I've heard of these, where let's say you've got a mom and her 3 daughters, that mom's mother, who's the grandmother, and her other daughter, an aunt, and her 2 daughters, and they've all had breast cancer. You'd probably say, wow, that really, runs in the family, right? And so you may have one of the daughters, maybe there's one daughter left from that first mom who hasn't been diagnosed with cancer yet, but all the women in her family have. She knows she's at high risk. The doctors know she's at high risk. So she decides to get some genetic counseling to find out what kind of screening do I need to get done. And because of the extremely high risk for me, would it be a good idea to go ahead and have a optional, gosh, my brain's not working, mastectomy, have her breast removed because maybe the type of cancer is a very risky one, meaning it's like BRCA, one of the high ones. And so that might be a choice that she does so that she doesn't have to go through that. We've read about a lot of actresses who've chosen to do that because of the strong familial tendency or hereditary tendency. And they've tested positive for some of those genes to show that they have that risk factor. Angelina Jolie was one of those, who made those choices after her mom passed away from ovarian cancer, and she decided that she never wanted her kids to go through that. And so she chose, to have a mastectomy and a hysterectomy. I believe she had both, in order to prevent that from happening in the future because her numbers tested very high for that. Okay. The next thing we talk about are the warning signs, or the early warning signs for cancer. And we call this the 7 warning signs. The American Cancer Society has identified 7 warning signs that are associated with many types, common types of cancer. They guide nurses and the public in identifying signs and symptoms that require medical evaluation, meaning if you have one of these 7 symptoms, you should get them checked out. You shouldn't wait, okay? The first letter of the warning sign of each one spells out the word caution, which helps us remember that mnemonic, okay? Making it easier. So, caution, C, stands for any change in bowel or bladder function or habits. A lesion that does not heal. U, an unusual bleeding or discharge. T is thickening or a lump. I is indigestion or difficulty swallowing. O is obvious changes in a wart or mole. Or N, a nagging cough or persistent hoarseness. Okay, and then some places add the up at the bottom, caution up. U standing for unexplained weight loss, and P standing for pernicious anemia. Okay, to name a few. Let me give you an example. This has probably been about 2 years ago, I would say. And my husband and I were in bed one night. I think he was reading and I was probably on my phone. And I looked over at his ear and I said, "Oh, what's that bump on your ear?" It was kind of like right here on the back, kind of curve of his ear. And he was like, "What?" And I go, "You've got a bump on the back of your ear." And he always teases me because I'm a typical nurse. Like, "What's that? Did you check that? What's going on?" And so I reached over and I felt it and I looked closer and it kind of had a shiny, this little, very evident bump with a shiny appearance to him. And I said, "You need to get that checked." And he was like, "Lori, really?" And I was like, "No, seriously, you need to go to the doctor and get that checked and make sure, because that doesn't look right. That looks kind of like those little skin cancers." And he was kind of like, So then probably a month or 2 later, that long, we went to the doctor and I went with him, and he was there for something else. And then I told the doctor, "Oh, hey, take a look at his ear. He's got something going on. You need to check out." And of course, my husband initially was like, and the doctor walked straight over, looked at it, and he goes, "Yeah, that's skin cancer. We need to get you into a dermatologist, like right away." And my husband looked at me like, "Oh my gosh, like, you're right." And he did have to go in and get the Mohs procedure where they shave it down, to each layer until there's no longer any cancer seen in the microscope. And we did that over a day. But yeah, perfect picture, an obvious change in a wart or mole or a thickening, or a lump that you see, any of those things that look different. It's not the same as it was before. Ask about it, get it checked, right? Because you never know. Okay, so those are good things to be able to talk to your patients about. Okay, so again, the warning signs of cancer. Think about caution and each letter for that. Okay. Next thing we talk about is prevention and early detection. And these are really important, okay? Because we have health promotion, avoidance of carcinogens, identification of high-risk people so that we can take better care to recognize something before it gets too bad, right? And screening for cancer. These are all huge things for prevention and early detection, because what we want to educate our patients on is that, if we can identify it early and catch it before it spreads anywhere, then so many times it's a very simple fix. It's when we ignore it, when we don't go get it checked, or we're too scared to get it checked, that then it progresses beyond when we can do something about it. So many times too late. Let me give you an example. My husband and I are pastors, and our associate pastor, it's been about 5 years ago, almost, it'll be 6 years in the fall. He was diagnosed, that's about the time he passed away, excuse me. So it's probably been 9 years ago, 9 years ago now. And he was about right around 60, 59, 60. And he hadn't gotten a routine colonoscopy that they recommend after the age of 50 to 55, typically 50, for men. And so he kept putting it off and putting it off, like as in 10 years. And kind of started having some tummy issues and thought, I really should probably get in and get that test done. My doctors told me I need to. And he went ahead and scheduled it to get done. They couldn't complete the procedure because they couldn't advance the scope past a certain area in the colon. Then they sent him to get blood tests done, which his numbers weren't too bad. Understand, based off of what we found out later. And I actually worked at the hospital at the time that he was going to. And they decided to go in and do an exploratory surgery because they were able to see that there was probably some blockage in his colon. And there was a chance that, he could have a tumor or polyps or something blocking, which of course there was concern. And I happened to be working that day. And I happened to work in the surgery department at the time. And my friend who was taking care of him after he came out of surgery didn't know yet that he was my friend, because I was doing pre-op and I came in, said, hey, how's he doing? She didn't know that I knew him, but of course it was a patient I had admitted and it was part of admission. And so she just said, oh, I feel really bad for the guy. They opened him up and there was cancer everywhere. And I was just in shock because my husband was out in the lobby with his wife and family. And perfect picture of something that could have been caught so much earlier just by preventative testing and screening, regular screening prevention. And, thankfully he had 3 more years. They had to fight it, but it was very brutal and ended very difficult. But again, so many people, and they will confide in us so many times as their nurse by telling, by coming into appointments and you ask them questions like, do you have anything you're worried about? And you kind of see them hesitate. And sometimes you'll say, is there something you're concerned about? And sometimes they'll open up and say, well, it's probably nothing. Don't just go, oh, okay. Explore it further, because sometimes it's something that they're afraid of or, self-conscious about. Like, for example, like our friend, maybe what they're having issues with is they've been having kind of some changes in their bowel movements. They're not the same as they've been, or a little difficult, but they're too embarrassed to talk about it because they think, oh, well, I'm getting older, it's probably normal. Not knowing that they could have something progressing. And, maybe it's a benign, maybe it's something that we don't even need to worry about. But what if it's not? If we can catch it early and we can educate them well enough to know that, hey, don't let fear stop you, because the earlier you get checked, the better your outcomes are going to be, right? I watched what our friend went through. I don't ever want to go through it. Colon cancer runs in my family. I've had the genetic testing done. So instead of every 10 years, I have to have a colonoscopy every 5 years. I am on top of it because my attitude is it uncomfortable to have to do that test every 5 years? Sure it is. Way more uncomfortable to go to chemo every day and radiation and surgery and have to go through that. Make sense? So I think it's so important that we educate our patients well on there being so many options nowadays. And so health promotion, how to avoid carcinogens, looking at those who are high risk, if they have a family, familial or hereditary risk factor, let's do something about it. Let's stay on top of it, right? Okay. So those are really big. There are a lot of behaviors associated with good health that can reduce the risk of many cancers. There also, your reading talks about what beverages and foods should be taken in limited quantities to help decrease the risk of cancer. Most people don't usually like this one. Decreasing alcoholic beverages, foods that are salt cured, smoked, or nitrate preserved should be consumed in very limited quantities because they've been proven to have and or increase the risk of cancer. Public education, again, has focused their attention on carcinogens, and people are becoming more aware of the need to avoid them. Guess how many people quit smoking each year? 1 million people every year quit smoking. That tells us that our education process is working better than it used to. Okay, may not be perfect, but it's explaining and getting people to understand how serious it really is. Okay, on a broader scale, the legal restrictions on public smoking to help reduce the exposure to secondhand smoke on non-smokers has also significantly made a difference as well. You know, that's good to remember as well. So question A, what are the characteristics of characteristics of cancer cells include the following except for what? A, cells readily recognized by other cells. B, they may have abnormal proteins called tumor markers on cell surface. C, random, disorganized, uncontrolled growth pattern. Or D, the ability to migrate from one tissue or organ to another. Which one? It says the characteristics of cancer cells include the following except. Which one? The answer is A, cells readily recognized by other cells. A, cancer cells are not readily recognized by other cells. So that one would be false. Okay, we move to the next half of your objectives. Laughing because you can still see the oxygen tank for my husband in the background. Hasn't had to use that one, thank goodness. All right, so the next thing we talk about is the diagnosis of cancer, when somebody actually is diagnosed, okay? And we are looking at their health history, we're looking at their physical exam, diagnostic procedures. This one's big. We're going to spend some time here talking about this for a minute. When cancer is suspected, when high-risk people are screened, or when determining the extent of the known disease. Also, tissue examinations, imaging studies, endoscopic procedures, and lab tests. These are all part of being able to diagnose cancer, okay? So, the health history, physical exam are often things that provide those first clues to let us know that there could be the presence of cancer. Okay, combination of different procedures may be indicated for cancers that are difficult to locate or to determine whether or not there's more than one site, right? If it is here, has it spread anywhere, right? And we have to find that out so we know what to plan for their plan of care. Now, one of your questions asks, are there lab tests that are specific for cancer? Yeah, there are. So see table 7.7 on page 109. This is going to be a key table for you to focus on, okay? Talking about different diagnostics and procedures. Okay, I want you to read through each of those, okay? Really paying attention to those endoscopic procedures that we mentioned, you know, your MRIs, CTs, and so on, okay? And knowing what types of exams they're used for. Okay, as well as your tissue examinations at the top. This shows that, yes, we look at all these different areas in the body and different cells to find out what's going on. Remember again, on page 106, we just talked about it, the TNM staging again, system for cancer. Make sure again that you study that one well, okay? Also on table 7.6 at the bottom of page 108. This one is a really important one to study too. They pull a lot of your questions out of some of these charts on this chapter, okay? Because again, it pulls you into being able to apply these to your patients, okay? For example, on your cancer screening test, what if you have a woman coming in to get her annual Pap test, right? Well, for example, we're looking for what? Cervical cancer. That's a big one, right? And so what do? The Pap test can find abnormal cells in the cervix, which may turn into cancer. We would call those precancerous cells, okay? The HPV test looks for the virus, the human papillomavirus, that can cause these different types of changes in the cells. Pap tests can also find cervical cancer early when the chance of being cured is very high, okay? Cervical cancer is a perfect picture of women needing to do those annual tests, you know, or as they're younger, a little bit further apart, and then annually after that. And that's cervical cancer is very slow growing. So if we catch it in the early stages, we have a chance of completely getting rid of it and eradicating it. That's pretty cool, okay? Which other ones do we talk about there? Colorectal cancer. Colorectal cancer almost always develops from a precancerous polyp. These are abnormal growths in the colon or the rectum. Screening tests can find those precancerous polyps so they can be removed before they turn into cancer. Okay? Those screening tests can also find colorectal cancer early when treatment works its best. And then that keys off, that's on page 108 in the chart, Page 109 then talks about which exam would they use for that, like an endoscopic procedure, where they take lighted tubes into those hollow organs or body cavities in order to view the tissue, take specimens of suspicious tissues. They'll do, for example, in a colonoscopy, they would do that in the colon. For the lungs, they would do a bronchoscopy. For the urinary bladder, they would use cystoscopy. If they were just looking, specifically in an abdominal cavity, it'd be laparoscopy. So it shows you different types of, tests that they would do. And then, of course, on the lungs, the U.S. Preventative Services Task Force recommends yearly lung cancer screenings with low-dose CT scans for people who have a history of heavy smoking and smoke now or have quit within the past 15 years, as well as being between the ages of 55 and 80. Okay? The next thing we talk about is surgery. So when we're talking about cancer, surgery is used to diagnose and stage the cancer, like it was with my friend. Okay? It's also used to relieve symptoms. Okay? I have a friend whose dad had esophageal cancer, and it was overgrowing into his esophagus where he was having trouble swallowing. Okay? It was putting pressure when he was eating, so they went in and put a stent in to push it back. It wasn't curative, but it allowed him to be able to eat and do well that way. Helps to maintain function, affect a cure sometimes, or even reconstruct an affected structure. It can be extensive or it can be simple. Treatments based on the type of cancer, where it's located, what stage it's in, and the extent of the metastasis. Makes sense, right? Treatment's going to depend on all those different factors. If it's just contained in one little area, well, that's going to be very different than if it completely spreads out and then metastasizes elsewhere. Okay, the surgeon will often consult with a radiologist and an oncologist to determine the best therapy for that patient. And there are so many factors that go into it. The ones we just talked about, as well as what type of cancer it is. Okay, all of those become very important. Surgery is most likely to be curative when those tumors are discovered early on. Makes sense, right? Because they haven't progressed further. Also, for tumors that are slow growing, tumors that are confined to one area and haven't invaded any vital body structures. Okay. Now, there's another term called radical procedure. What does that mean? That means when a surgery is extensive, then it's often referred to as being radical. That's on page 108. We have a couple other terms, adjuvant and non-adjuvant therapies, that are relatively recent approaches to cancer treatment. Your adjuvant therapy are things that can be used when a patient has had surgery or radiotherapy and they're now free of signs of disease. However, they have a high likelihood of reoccurrence, so they may use adjuvant therapy to work along with it. Non-adjuvant therapy uses chemo in order to reduce the extent of a tumor before surgery or radiotherapy. So for example, let's say that you have a tumor that's compressing on an area that's really unsafe. And if they can get it to shrink down before they actually do surgery, the surgery itself will be much more successful and safer. That would be a perfect picture of that. Okay. Next thing we talk about is radiotherapy. You have ionizing radiation that's used in the treatment of disease. It's used to treat cancer because malignant cells are more sensitive than your normal cells to radiation. Immediate and delayed effects on the cells, those occur. We're going to talk about those in a moment. Radiotherapy is given internally or externally. You also have caregiver safety, and you have side effects. Okay, the unit of measure for radiation used to be called rads. It's now called the gray. Okay, go figure. It's on page 109. I never, worked with cancer patients other than, surgery where we would bring them in to have surgery with a surgeon. So I haven't been super familiar with all of the ins and outs of oncology. A tumor is considered radiosensitive if it can be destroyed by radiation at a dose that is tolerated by the surrounding tissue. So for example, radiation can hurt our good tissue as well as the cancer tissue, but because your cancer cells are much more sensitive, they will be affected before the normal cells are. So we want to use enough to affect the cancer cells, but not the normal tissue, okay? External radiation is given by way of a beam that's, directed right at the tumor, okay? Less time is spent near the source, and then less exposure is incurred, okay? Radiation exposure decreases as distance from the source increases, okay? Makes sense. The closer we are, the higher chance of exposure to radiation. The further away we are from the source, the lower the chance, okay? Side effects are usually not evident until at least a week after the treatments are started. It takes a while. Then you have chemotherapy, okay? These are chemical agents that are used to treat disease, administered by a physician or a nurse who's had specialized education. The route is either oral, intramuscular, intravenous, intracavity, or intrathecal, okay? And there, of course, are a lot of side effects. In some cases, chemotherapy is curative. It works. It's amazing when it is. Okay, in other circumstances, it can reduce the number of cancer cells, causing the symptoms to decrease and often prolonging life. Maybe it doesn't cure it, but it keeps knocking them down low enough that that person can have a good quality of life for a lot longer. Now, sometimes they'll use a combination of chemotherapy drugs to be used. Talks about this on page 113. And that's because various types of cancer are sensitive to different types of drugs or drug combinations. Combinations are sometimes used to attack cells at the different stages of development or to target different cellular mechanisms, how they work. Okay, so drugs that are effective, for example, only during a particular phase of that cell developing are said to be what's called cell cycle phase specific, not complicated at all. And drugs that are effective during any phase of cell development are said to be cell cycle phase non-specific. So it just kind of gives you an idea of why they might use, several different combined drugs together. One's affecting this phase, another's affecting that phase, and so on. Okay, chemoembolization. This one's fascinating. This is a technique in which the drug is injected directly into the artery that supplies the tumor. So it's kind of like you having a direct access, okay? And they put it in that artery and it feeds right into that tumor at the source where it's getting fed the blood, and it actually will kill it that way. There are different organs in your body that may be at risk for toxic effects during chemotherapy. Depending on the specific anti-neoplastic agent, the patient's at risk for toxic effects on the heart, the lungs, the nerve tissues, the kidneys, and the bladder. So we have to be real careful with those, because then, those organs can begin to malfunction because of that. Now, although bone marrow suppression is the most dangerous side effect, nausea and vomiting are usually the ones that are super distressing to patients, okay? So those have to be addressed by us as nurses. And we're going to talk about that. You have a chart that I want you to look at and look at what different things and medications are used for nausea and vomiting, your antiemetics, okay? Biotherapy is another term we use. Hematopoietic growth factors. These are colony-stimulating factors that stimulate the bone marrow to produce our platelets, red and white blood cells. What our white blood cells do, they fight for us, don't they? They're like our army that fights off infection, okay? So biologic response to modifiers, BRMs, these are intended to boost the body's existing defenses, okay? It's like helping what it does, do it better, okay? The BRMs act directly on malignant cells, or they stimulate the immune system to act against them, okay? And then you have your monoclonal antibodies. These are specific for proteins on the surface of certain cancer cells, okay? Now, one of the questions I have is on page 114, and that's how do hematopoietic growth factors reduce the risk of inflammation? So why are these important? Why do they work? Well, they are one type of biotherapy, and they include what's called a colony stimulating factor. Because anti-neoplastic drugs suppress our bone marrow, CSFs may be used for supportive care in patients who are receiving that aggressive therapy, okay? So that cause myelosuppression. CSFs stimulate the bone marrow to produce the platelets, red blood cells, and white blood cells in patients receiving chemo. So when we're receiving these therapies like chemotherapy, it suppresses the production of our bone marrow. It produces the platelets, the red blood cells, the white blood cells. So we become anemic, right? And our ability to fight off infection goes low. So if we can give hematopoietic growth factors, these stimulate the bones to produce the platelets and the white blood cells and the red blood cells. And what that does is it builds up our chance of being able to fight off infection. Okay, so it shortens the period of neutropenia, meaning low white blood cell count, okay, which happens with chemotherapy as well as with anemia. Okay, the most common side effects of BRMs are extreme fatigue, headache, muscle aches, chills, and fever. Lots of side effects with these meds. Okay, the next thing we talk about, bone marrow and stem cell transplantation. Bone marrow transplantations used after treatment of leukemia and lymphoma with chemo and or radiation that destroys our bone marrow. Okay, we want to replace it. Stem cell transplants treats the destruction of the bone marrow that's caused by chemo and radiation or radiotherapy. Transplantation of bone marrow or peripheral blood stem cells restores the blood manufacturing cells. Okay, and these are pretty fascinating to watch, really amazing. I've only watched videos. I've never actually gotten to see a patient receive one. I probably walked through a room when they were getting them, but unaware. If a patient donates his or her own stem cells or bone marrow before therapy, that would be classified as an autologous or autologous transplant, meaning it's their own. Okay, an allogenic stem cell transplant is if they receive cells from a sibling or relative. Okay, if they're from a donated and unrelated person or donor, then it's classified as a matched unrelated donor transplant. It describes those on page 117, just so you understand. If they store their own ahead of time, that's what, autologous or autologous. If it's from a family member, sibling, that's allogenic. If it's from somebody they don't know, but it's a match, then again, it's matched, unrelated donor transplant. Okay? Then we have what's called hormone therapy. There are various treatments that suppress the natural hormone secretion. They block hormone actions or provide supplemental hormones. Sometimes one of the issues with cancer is you have certain hormones that will actually promote the growth, whereas other ones will help decrease that, okay? Hormones may be used to block the male sex organs, for example, in the treatment of prostate cancer, and female hormones in the treatment of breast cancer, again, depending on what kind they have. Another big one that we talk about that you've probably heard a lot about already is complementary and alternative therapies for your patients with cancer. Non-traditional treatments, these are things like relaxation techniques, guided imagery, music, meditation, herbal remedies, and acupuncture. Okay? Complementary therapies are things, it's non-traditional therapy that's used along with conventional therapy, as in it complements it. Okay? Alternative therapy, this is where the patient uses non-traditional therapy in place of traditional treatment. Okay? It's an alternative. It's used instead of. Complementary, it's used with. Okay? Research is being conducted by the National Center for Complementary and Alternative Medicine and the National Institutes of Health to determine the therapeutic value of different non-traditional treatments. Okay? And so that one comes into play a lot. We've seen a lot of amazing studies done on how different things really do work. Problem is there's a whole bunch of things out there that don't, that people are convinced and told that they do, which is sad. One of the reasons why your patients should report anything they're using, herbal supplements, natural supplements, what have you, is because, again, they may be things that affect the prescribed medications. It can cause delays on actually using something that really will work. Okay, so it's super important for our patients to let us know what those are. And sometimes they're embarrassed too, because they're willing to try anything at this point. And then you have your unproven methods of cancer treatment. Okay, the American Cancer Society discourages treatments that haven't been studied yet. Okay, Alternative therapies can be harmful and they may delay treatment with potentially effective conventional therapies. So again, what you're really saying is you're not telling your patients don't use alternative therapies. You're saying make sure you study out the information and make sure it's legit. Okay, don't just try anything that somebody pops up on a Facebook ad that says, oh, this will cure cancer. And then they take that instead of the cure that actually could help, and it didn't do any good, right? Studies have found that 6 to 9% of patients with cancer admit to using some type of questionable method of cancer treatment. And most people would, right? They're like, I'll do anything if I can get this to go away. Okay? I think that it says studies have found that 6 to 9% with cancer have done that. I think the numbers are way beyond that because that's just the research numbers, right? Now, when we are caring for patients with cancer, we divide these into diagnostic and treatment phase. These are pretty big in your book, and we're not going to get into every topic. There just isn't time for it. But I want you to read through it, when you are going through your reading, okay? Because it's super important for us to understand a lot of these different methods, that are placed in your book. Okay, for example, you go into the diagnostic phase and it takes you through your focused assessment, health history. There's a great case nursing care plan I want you to look through in the middle of that. Talks about the different interventions, everything from denial and anxiety and so on. We're going to talk through a few of those for each one under the diagnostic phase and then under the treatment phase. But please make sure you read through each one of those because it'll really give you a bigger picture, okay? So diagnostic phase on page 119 has that nursing care plan I was referring to, okay? And it goes through each of the patient problems. It gives you your goals and outcome and then your intervention. I'd like you to focus, I want you to read through all of them, focus on the top 3 there listed of patient problems. I think those will help you, okay? It takes you through, for example, anxiety that's related to the effects of treatment, inadequate knowledge of the prescribed therapy, potential for injury, and each of those help you to understand that a little better, okay? In 2007, research by Franks and Roche found that individuals with cancer who appraise their illness as a threat are likely to use more problem-focused coping strategies. Those who appraise their cancer as harm or loss are likely to use more avoidance coping strategies. And those who appraise their cancer as a challenge are likely to use the approach of coping strategies. It's on page 121. Study that one out, okay, so that you understand that. That's important. The next thing I want you to talk about, I want you to read, is on page, let me find it here for you, 124. Okay, on page 124, you have medication therapy, commonly prescribed antiemetics in table 7.11, 7.11. Okay, make sure you study these, know the classification, the specific drugs, and side effects, okay? Really read up on your phenothiazines, antihistamines, corticosteroids, and your cannabinoids. I'll give you a little bit of focus there, okay? So that you understand those medications. And what are these all used for? They're antiemetics, right? Anti-nausea, anti-vomiting drugs, okay? Super important to understand that, okay? And then page 121, 122, we're going to back up there again. There's a lot of different charts here that they really key off of, so I'm trying to give you some information on this, okay? Starts out with the chart at the bottom of page 121 under treatment phase called Patient Problems, Goals, and Outcome Criteria for the Cancer Treatment Phase. I want you to study that well. It goes into the next page. So I'm going to give you some focus points because it's a huge chart. Okay, I want you to start with altered body image about 2/3 of the way down and work through the rest of those. You should be reading all of them because those do come up on the HESI. I'm giving you a little bit of focus for your information, okay? So again, think about, each one of those. So for example, if you start with altered body image, well, let's go up a little higher. Let's say you're looking at the patient problem of constipation related to decreased activity and drug side effects. What's my goal? What are my goals and outcome going to be? Normal bowel elimination, soft forms, stools passed at least every 3 days. You follow me? Altered body image related to alopecia, which is what? Hair loss, right? Surgical scars, loss of function, or stoma. What are your goals and outcome criteria going to be? Adaptation to change in the body, patient demonstrating acceptance of their hair loss and scars or conceals them, adapts to functional changes and adjusts to stoma, and learns self-care. See how we took the problem and looked at what our outcomes that we want them to be. Altered family dynamics related to illness and therapy, adjustment of family roles and relationships, and reassignment within the family. So you see how that chart works. Those are really great. Please study that one out, okay? Page 125. I'm just pulling out some key points since we can't go over every single item. 7.5 is called recommended food and beverages for the patient with nausea and vomiting. Please study that chart well. You should be able to look at that and say, oh, well, that makes sense. These are things that are mild on the stomach, things that most patients aren't going to get nauseous with, things that settle easily. And you're going to want to make sure and look at those because, you know, if you're working with with a dietitian or somebody who's planning meals, you should be able to recognize which foods would be best for that. All right, recovery and rehabilitation. If the outcome of treatment appears to be a cure, the patient and family, of course, are usually overjoyed. Some patients become excessively concerned with their bodies, constantly looking for new evidence of cancer. I had a student who talked about this, who had gone through quite the ordeal with breast cancer. And she said that it took a long time for her not to become just obsessed about making sure that there was nothing else present. Periodic checkups are essential, but they may be dreaded because if the patient realizes that complete or permanent recovery can't be guaranteed. So they're always scared to go into appointments. Like, what if they find it again? And it becomes very scary for them. Okay. If signs of possible reoccurrence, then of course your patient's concerned. Like, I know this is a symptom I'm supposed to watch for. Here it is. Now what do I do? Okay. And then as the patient recovers from the effects of cancer and cancer therapy, rehab may be needed to restore them to, again, their highest possible level of functioning. And you're going to notice that again throughout the rest of this mod and the next. And that's that we're always looking to restore our patients to their highest possible level of functioning before they began to deal with this. Okay. Only a few more here. Terminal illness is the next one. We talk about terminal illness starting on page 127. Although increasing numbers of people are surviving cancer, it's still important to remember that it's the second leading cause of death. Okay? If treatment is unsuccessful, your patients will begin to decline. Okay? For patients who wish to die at home, hospice is a great option to provide support and teaching, which we just talked about the other day. Okay, the focus of hospice is to keep your patient's symptoms, especially pain, under control during their final period of illness. Okay, also it provides bereavement care after the patient's death for the family, and that's pretty amazing as well. Okay, you want to provide information about home health care, hospice, and voluntary and charitable organizations whose services might be needed during these times. You also need to be aware of how to work effectively with your terminally ill patients. Okay, how do you do this? Well, first of all, you need to be aware of your own feelings about dying, because if we don't know how we feel about it, we're not going to have a very good time helping our patients with it, right? Now, really important, when you're working with terminally ill patients, patients who are near the end of life, some of the big things we're worried about: making sure they have sufficient pain control, okay? Using therapeutic touch, that's important to people, and the nurse being present with the patient, very important, because patients don't want to be alone, okay? So those are some really important things to make sure you really key into, Okay, so basically we're looking at being attentive and accepting with our patients, giving their, your book talks about on page 127 what's called medication cocktails. You don't hear that term as much anymore of using it that way, but that's when they would use pain meds and other meds together so that the patient wouldn't be quite as sedated, but yet they were being kept comfortable. Okay, a variety of approaches should be tried to keep the patient as comfortable as possible. This is really important. With severe chronic pain, it's very appropriate to medicate the patient at fixed intervals rather than upon request, meaning we don't want the pain to build. We want to keep them medicated. Remember, again, it's easier to keep the pain down than to bring it down, okay? All right, the patient may have pain at specific or during certain activities despite getting routine analgesics. That is referred to as breakthrough pain. If that happens, there may be an order for additional meds as needed, or PRN, and you would use those short-acting drugs with rapid onset of action. You'd never withhold the ordered opioids out of concern about causing addiction. These are patients in the end stages of life. We're not worried about that. Okay. There are a lot of times when patient starts having breakthrough pain a little bit before the next dose is due. And when you're talking about terminal illness, there are other parameters that doctors have, for example, of going ahead and giving that dose and then calling the doctor and, getting that another order for breakthrough meds if they haven't already had one. Okay. And then the last thing are oncologic emergencies. These are conditions, sadly, that sometimes develop that require emergency intervention as a result of that disease process or therapy. Okay. What are some examples? Hypercalcemia, syndrome of inappropriate antidiuretic hormone, SIADH. Okay. Disseminated intravascular coagulation, known as DIC. Superior vena cava syndrome, and spinal cord compression. Okay, so those are some things that can cause emergencies for that. On page 128, table 7.12, it'll walk you through 5 different oncologic emergencies that you can read through, what the risk factors are, the signs and symptoms, how we treat them, and what our nursing care is. Okay, so those are important for you to take a look at and understand. So we'll finish out with question number 2, asking which of the following is a true statement about radiation. Okay, so I lost the end of my chapter here. Patients treated with an internal radiation do not pose a threat to others. A tumor is considered radiosensitive if it can be destroyed by radiation. Whoops, just lost that on the screen. Well, I'll just read it to you then. Sorry about that, lost our screen there. Patient 2, a tumor is considered radiosensitive if it can be destroyed by radiation at a dose that is tolerated by surrounding tissue, normal surrounding tissue. The immediate effect of radiation is altered to DNA, which impairs the cell's ability to reproduce. External radiation requires the introduction of the radioactive substance into the body. Okay, so what do you think? What did you find with that one? A, B, C, or D? I didn't figure out what my screen wasn't sharing. The answer is B. And that's that a tumor is considered radiosensitive if it can be destroyed by radiation at a dose that is tolerated by the surrounding normal tissue. And we read that earlier as we were going through that section. That gives you a good picture of the patient with cancer. So make sure again that you are reading that chapter well, go over those NCLEX questions, go over the review points, but there are a lot of different topics because again, you're looking at, especially the section, like I told you when we're talking about actual nursing care of the patient with cancer. Because again, you go from the diagnostic phase, all the different things we deal with, everything from, anxiety and denial and the physical exam, all of that, to your actual treatment phase. And that breaks down again into your focused assessment. health history, physical exam. And you look at the interventions of anxiety, inadequate coping, um, and then your different potentials for injury for patients who are going through this. You've got everything from pneumonitis and pulmonary fibrosis, cardiac toxicity, neurotoxicity, cystitis and diarrhea, thrombocytopenia, anemia, reproductive cells, and it goes all the way into your high risk for infection, which we talked about. Also, what happens to the oral cavity, impaired oral tissue cavity, constipation, fatigue, altered body image, grieving, altered family dynamics, lack of readiness for self-care. And then, of course, it breaks down into the different ones we talked about. So I know there's a lot in that little section right there, just helping you understand, what these patients have to deal with, and it's a big deal. So for us to have just a simple understanding at least can give us a lot more compassion, knowing what our patients are dealing with. Okay? All right, guys. Good luck studying for that chapter, and I will see you with our next lecture.